sarcopenia. So we may be knowing when we mean by sarcopenia, the first DD that comes to our mind is malnutrition. So reduced muscle mass but with normal muscle strength. When it comes to malnutrition, there is a normal muscle strength will be there, but because of decrease in the protein intake, so the muscle mass will be lost, but the strength will not be lost in malnutrition. So that differentiates how malnutrition can be differentiated from sarcopenia. Reduced muscle mass with impaired muscle function, as we had discussed, suggests sarcopenia. So that is the first DD that comes into our mind. The second DD that comes into our mind is cachexia. So when we talk about cachexia, we always look at cachexia where the muscle mass as well as the muscle wasting, when it happens with diseases, terminal diseases like cancer, HIV and AIDS, or with end-stage organ failure. So when it comes to the terminal stages or an ongoing disease process, then we call it as cachexia. Sarcopenia happens in a normal aged women, like the diagram, the picture which we saw earlier, no? That is sarcopenia. Whereas when it is associated with diseases like these conditions, it is called as cachexia. But in an individual, both cachexia and sarcopenia can sometimes coexist. So that is also we need to remember for clarity. Cachexia always has a complex pathophysiology. It includes excess catabolism and inflammation. There are endocrine changes, neurological changes. All these things differentiated from sarcopenia. So we need to differentiate cachexia from sarcopenia with this angle. But when we talk about sarcopenia, okay, we have understood about what is sarcopenia definition, how does the patient presents. But why do we need to talk about all these things in diabetes module? So why should we talk about sarcopenia over here? As we understand about the pathophysiology of diabetes, you can just go back and have a look at our pathophysiology topic. So the diabetes pathophysiology has moved from triumvirate from 3 to ominous octet. We have discussed all these things. So in this triumvirate, we always talk about there is an impaired insulin secretion, increased hepatic glucose. In the presence of all this happens in the presence of insulin resistance. But something which we never look at all is this decreased glucose uptake by the tissues. So this is very, very important. We don't talk about this much because we can't do, like we have drugs to address this, we have drugs to address this, we have drugs to address this. But how can we address this with the drugs? So we don't talk about this at all. But please remember, since our understanding of diabetes has evolved for the past 30-40 years, it is always in the picture that there is a decreased glucose output which we seldom talk. So that is very, very important, because if the glucose uptake by the muscles and tissues is decreased, it will produce increased blood sugar in the body. It will produce a hyperglycemia. So it is with this view we need to understand how decreased glucose uptake also can produce hyperglycemia.